We're now going to move on to Sadie, who as a consultant anaesthetist is utterly essential to that stabilization. And I mean, Sadie is known not just for her work as a clinician, but also as an educator, particularly multidisciplinary simulation. And I think Sadie, you're reminding us around some of that organisation, but I think you've also done a little bit on revising some of the underpinning pathophysiology that provides the rationale for why transfusion has become a focus of some of these incident reports and inquiries that we've seen. So may I hand over to you, and thank you again for bearing with us. Bye now.
Thank you, Heidi. Thank you very much. And thank you for inviting me to speak today. I want to talk about, I have followed on from two major experts in the major incident field, but I want to talk a bit about preparing for a major incident as an anaesthetist and what our perspective is, and therefore how it works for us in hospitals. So we've all talked about 2017. 2017 was a very big year across this country and across the Channel as well. And it started for us in London on the 22nd of March when Westminster Bridge attack occurred. It's a day I will never forget. It was the first of many family events I was about to miss that year, including on that day, my son's second birthday. And I didn't get home to get to see his birthday. And 2017 ended with the Finsbury Park attacks for us in September, but a big part in the middle of that was the Grenfell Towers fire, which happened in June. Again, another birthday missed, and that was my own. Move on, please, Fats. So I want to, everybody's emphasised how information gets passed about when we hear of a major incident occurring. And what's really important to understand is there's a huge amount of uncertainty. Kareem Brohi and Rosal Talak wrote a paper in the British Journal of Anaesthesia a couple of years ago talking about us embracing uncertainty in a mass casualty incidents. And that's because we are fed little bits of information and we don't know a huge amount. And Professor Smith explained that in his talk just now. And we don't always know whether we're making the right calls or the right decisions or judgments based on what information we are receiving kind of minute by minute. And sometimes we're not going to know what the true events are and what's happened and what the outcomes are until weeks, if not months later. At St Mary's, where I work at Imperial College in London at the Major Trauma Centre, we receive a phone call or a text message from our switchboard, which declares, as you can see on the left-hand side for the 22nd of March, we declares that St Mary's was on standby for a major incident, and then it was then declared, and that's how we receive our messages. And we then need to make our way into the hospital. Next slide, please, Fabs. So what happens now for us as anaesthetists? Well, if you are in the hospital, that's great. If you're not in the hospital, like as my first slide alluded to, major incidents can occur at any time of the day, any time of the year, and in any location. And we can't predict when that's going to be. So in terms of the Westminster Bridge attack, I was educating in another site on another part of the hospital, and we heard the information as we were leaving that educational event. And as a group of colleagues who are all involved in major trauma, including our major trauma lead at the time, we all got into a cab and got ourselves to St Mary's. When the Grenfell Tower fire happened, that was in the middle of the night, and I was called in by my consultant colleague who was already present on the floor dealing with another operating case in the operating theatres. So as we're arriving, we're trying to get into work. We need to find a sensible way to get there, and we're mentally preparing ourselves at this point as to what we might be facing, and that's based on all that uncertainty and all the information that we haven't yet received. Every induction for any member of staff starting in a major trauma centre will include the major incident plan and its action cards. And we certainly hope that nobody is entering the hospital at that point having not read it. But once you've read it in anaesthetics, we have a plan where we arrive onto the operating floors in our hospital and we sign in. And that's to allow people to appreciate that we're already in the building and what our roles are. Leadership is different slightly. We go back to the command and control system when it comes to a major incident. And for us in anaesthetics, that usually means that there is a silver command in the emergency department for anaesthetics, and they will be stood in the centre of the emergency department with the trauma team and incident control commanders, taking information in as is required and passing it to the appropriate areas. In our operating theatres, we have a bronze command consultant anaesthetist who is coordinating the floor. Again, as I said, with the Westminster Bridge attack, we had a fully operating set of lists happening, and they were all had patients on the operating table. And we need to work out at this point which operations are coming to a close, which theatres will come to a close, which theatres need to stop work if they haven't yet started any, so that we can free up as much space as possible. The leadership is also making decisions about how we continue to do work as usual, because we, of course, have labour wards. As anaesthetists, we need to make sure that we can still man our labour wards and ensure that we can carry out any caesarean sections or any emergency care that's required on our maternity services side, as well as other remote sites of our. We then want to, as leaders, assess the situation. So that's part of working out who we have in the room, but also which operating theatres are available to us. Where do we move operating in order to support any sort of trauma coming into the hospital? Part of that assessment is also about appreciating what resource we're going to need, and we do that by trying to gather the information from the field and the scene, from our HEMS colleagues and the incident control command within the field services, to let us know how many P1s we think we might be receiving and how many P2s and how many of those will need potentially operating procedures. Skill sets are really important, and I spend a lot of my time and career clinically and educationally talking about multidisciplinary teams and appreciating each other's skill sets and knowledge, and making sure that we have the right resource in the right place. We need to support all of the other command leadership roles that sit within our operating spaces. That includes our nursing leadership, our operating departments and our scrub nurses, and recovery teams. Each have their own command structure, and we need to be able to have conversations with them. Everybody's talked about communication quite in detail, and not surprisingly, and we've come a long way with things like WhatsApp groups, and we certainly at St Mary's have a major incident WhatsApp group, and one for the Charing Cross site and one for the Hammersmith site. And they get very busily filled when these sort of things happen with information that is not pertinent or helpful. So we make sure that we keep those channels clear so that only information that is required can be passed on. Next slide, please, Bats. So what next? What do we do next? Well, as an anaesthetic person in charge, for example, in the silver command position in the ED, they will send information up to bronze command, where we have set up teams in the operating theatres that we can send down when and where they are required. So we're not flooding ED with 20, 30 anaesthetists and their ODP counterparts. We are ensuring that we only send down team members that are required to keep that space as clean and clear as possible. Once we go down as anaesthetists and ODPs, we need to then do the human factors thing, where we fixate on the case that has been given to us. So we assess each case on its own merits. Every individual patient is different, and each of the polytraumas will be different. We then appreciate the roles that people have within our area of management for that patient. So whether we have nursing staff, specialist surgeons, a TTL, a trauma team leader, and any other staff around that area. And if we're dealing with children, we will have paediatric services as well. So we need to know what everybody's roles are, and having that clear brief before we actually do the management of the patient that's incoming is important to make sure that the roles are allocated appropriately. We also need to know people and staff are our major resource in a major incident, and particularly within the anaesthetic and operating department areas. But we also have a huge amount of equipment that we need, and medications and drugs that we need to have available to us. And those are checked on a daily basis, whether we're in a major incident or not, and they're double checked by a spare ODP to make sure that we have all of that equipment. It's always helpful to know the proposed pathway for a potential patient, and we discuss it in the brief if we are given any information about the potential injuries of the patient, but that assessment is an ongoing thing as we assess more and more about the patient and know what we need to do. And again, I'm going to keep emphasising, as have my colleagues, about communicating effectively. Next slide, please, Fats. So as Heidi said, I am just going to quickly take you back to a little bit about trauma and blood and what we are being taught and trained to do as anaesthetists. And trauma, unsurprisingly, the massive bleeding is a key problem in this area, and it is definitely a serious contributor to any perioperative complications, both within the hours coming into surgery and after surgery during the operation, but also potentially in the hours after. It is important that we recognise how much the bleeding has occurred, both pre-hospitally and very early on when they come into the emergency department, and that allows us to assess how far behind we might be and therefore be able to catch up when necessary. It is the major cause of preventable death, and as many as 6 out of 10 of those deaths that occur in the first 3 hours are due to massive bleeding. Next slide, please, Fats. Trauma-induced coagulopathy is something, as anaesthetists, we are dealing with continuously when it comes to trauma and major trauma patients. It is caused by a combination of kind of cellular hypoxia and shock, and that's due to the hyperperfusion, due to the lack of blood volume. And in turn, trauma that's caused tissue damage will also continue to add to this trauma-induced coagulopathy. It is present in about 30% of all trauma patients arriving in ED, so it's not infrequent, and it is something that we are trying to deal with quickly and early on, because not dealing with it will lead to further problems intraoperatively, and it's something that can come on intraoperatively and in itself provokes endothelial damage, further endothelial damage of the tissue cells within the patient's body, causing further problems in its physiology. And we will see this for not just the time that the patient is in our operating theatres or in the ED department, but for many days and weeks further on, where our intensive care unit consultants and colleagues are dealing with the immune response having deteriorated due to the trauma-induced coagulopathy and the coagulation system's cascade being abnormal. So this is something that we hone into all of our trainees, and certainly my consultant colleagues. It's the lethal triad, the trauma triad of death. And these 3 corners, each one of them worsens trauma-induced coagulopathy, and in turn change the hemodynamics and physiology of our patients on the operating table, leading to further decreased myocardial performance, worsening the coagulation cascade. And the biggest problem we face is metabolic acidosis and hypothermia. We live in the British Isles. We cannot escape the fact that we live mostly in cold weather. And so our patients arrive very cold, and it is absolutely paramount we start heating them up as soon as possible, as soon as they come through the doors of ED, and continuously on their travels through the hospital and up into operating theatre or the intensive care unit. Next slide, please. The problem with blood loss, and Chris Jordan, who's speaking after lunch, will talk a lot about how we turn off the tap in terms of damage control surgery. We do a lot of damage control anaesthesia as well, and that's because we understand that there is a huge hemostatic disturbance, which leads to this massive fibrinogen depletion, and in turn there's inadequate thrombin generation. We have impaired platelet function and fibrinolysis and fibrinolytic dysregulation. These all occur both instantaneously during a trauma event, but also throughout the hours and days after the patient has sustained that trauma. and we need to keep on top of it. Otherwise, that turn off the tap when there is, which will be the only way we can stop using a blood resource, becomes really important. So understanding this is really important. That's next slide, please. So my colleagues often joke with us as anaesthetists that everything that we talk about and everything that we manage and the way we do it is all about the A, B, C, D, E. We have an A, B, C, D, E for everything. Most people will joke that the anaesthetists A, arrive, B, blame, C, criticize, and then depart. So with trauma and major incident mass casualty events, we have some practicalities with our ABCD approach, and we'll just quickly go through them now. Next slide, please, Bats. So I'm sorry if this is quite a graphic slide, so if you don't like the images, please do turn away. The A stands for assess adequately. And when we have a mass casualty event, we need to be aware of what's happening around us in each of the cubicles, potentially in ED or in our operating theatres. But we're making clinical decisions with a degree of uncertainty, but trying to be sensible about the things that we do know. So, for example, the patient with the picture in the third picture along, this is a decompressive craniectomy. And many people underestimate how much blood you can lose from a craniectomy. You will find that you can't see it on the floor, but it's dripping into the kind of sieve of draping that the neurosurgeons have around their patient. And we can have a major transfusion associated with just a decompressive craniectomy with a single organ injury. The patient who has sustained a significant lower limb injury in the fourth picture, you can see that leg looks fairly unviable. So we're having conversations with senior experts at this point about whether we're going to go to an amputation or try to revascularize this injury. And obviously those two decisions or those two options lead to different needs for different amounts of blood. So there's no right one answer to how much blood a P1 patient requiring an operative procedure will require, but a lot of that is due to experience and understanding of the potential injuries and the needs that patient might have. In our A&E departments, we are ensuring that we get 2 group and saves. As Professor Smith said, it's really difficult sometimes to get those 2 group and saves, but information needs to be passed about whether a patient will receive O positive or O negative blood. So a person of childbearing age, for example, we would request O negative where it is resource possible. Next slide, please. B is for be aware. Again, with my human factors hat on, I'm totally into situational awareness. We task fixate on purpose, and that's appropriate because we're trying to manage a patient, but we do also have to have situational awareness when it comes to the resources that we have. So there is only so much blood stock in a hospital. If you have 4 operating theatres requiring all of that blood stock, we need to make sure that we're all on the same page and aware of what's going on. And that goes back to that leadership, command and control structure, ensuring that the communication is effectively going from each of the operating theatres to the command structure within anaesthetics and then to the floor and to the labs. This is why knowing how far we go with an operation, and Chris will talk more about when we start and when we stop in terms of damage control surgery, we need to appreciate what operation we're going to do and whether it's going to be immediately or in the days to come. And that can only happen when people have the appropriate knowledge and levels of seniority. So decision making happens at that level. Knowing our equipment is vital because they help support and prevent that lethal triad of death. So we often use in our centres a Belmont rapid infuser. This allows us to rapidly infuse blood products, and where needed in cardiothoracic centres, we will be using a bypass and perfusion machine. So it's all about early anticipation. You can only do that when you know what everybody else is thinking and appreciating that there are other things that can be used when a resource needs to be more available. So things like calcium chloride, tranexamic acid, using them as infusions in our operating theatres, but also things like tourniquets, which shouldn't be forgotten. Next slide, please. I think you missed one. Perhaps can you go back one? Oh, it's one missing.
I haven't got another slide there.
Okay, so
Apologies.
C stood, that's all right. C, I'll just say C stood for communication. Normally, when we're talking to our blood transfusion labs, we communicate on the telephone, and it is really important when we're giving information out that we treat our lab colleagues with their own expertise. And I spend a lot of time as a simulation lead ensuring that people communicate effectively and appreciate the roles that are in the lab. So now in our major hemorrhage protocol plan, we will pick up the phone and call the lab, and we will not just give them information about what products we want, but we will also tell them a little bit about what surgery we're planning to do, the mechanism of injury, because we appreciate that they are then able to plan for future stock needs and what might need to be called for and how long this is likely to go on for. That communication is really important. In our operating theatres, there is also continuous communication occurring, but at salient points. So we are stopping at appropriate times to touch base with each other as anaesthetists and surgeons and scrub teams. So we will stop where it's appropriate for the surgeon to tell us what they're planning to do next, and for them to gather how much blood product we may have been given, what other pharmaceutical agents the patient's requiring to be supported with, and where we think we might be going. This information is then vital in terms of making sure that everybody is in the same space at the same time, and there is a degree of professional culture clash where we use a lot of jargon, and part of that communication learning is to ensure that everybody in the room understood what was being said. So we try to cut out the jargon as much as possible and just keep it down to nice and simple structure so everybody is aware. D is for delegation. In delegation, nobody is a good multitasker. I will challenge anybody who says they are great at multitasking because it's just not actually possible cognitively. And so when we multitask, we do a job to a certain standard, but we don't do it as well as we could if we fixated on a single role. Anaesthetic kind of plan for blood management in polytrauma patient is to assure we have a blood monitor, and that blood monitor is our liaison between the anaesthetic head end and the lab. It isn't the most junior person in the room, which is often what I find when I walk in to see a blood monitor being assigned. It's the person they think won't be able to be more useful. Easiest thing to do is put them on the phone. And that's just not true, because a blood monitor needs to be somebody who has enough knowledge to be able to liaise sensibly with the lab, but also to have that communication, that conversation where we're queried and where we think where advice might be given by the lab in terms of what other things might be given. So it's really important that the blood monitor isn't the most junior person in the room. Talked a little bit about leadership and how leadership transparency is really important. So when a patient is transferred from ED, the person in charge of that patient is the trauma team leader. That leadership is then transferred possibly to the surgeon in the room, who will have a brief conversation with the whole team, ensuring that we're all on the same page. And while they're then operating, the leadership will transfer to the anaesthetic consultant in the room. And it may go back and forth where it's appropriate. The same applies with our ED nurses and ODPs. Again, communication to ensure that there is a smooth handover of things like the Belmont when blood has been given. We know how much blood has been given in the emergency department, and how much what we have with us that's been transferred up from the emergency department with the patient. All of that information is vital, particularly when it comes to traceability tags, and part of my role at St Mary's and Imperial alongside FATS is to ensure, and the team in the lab is to ensure that we get that information across to our colleagues, that it's vital to get these traceability tags filled out, because without which we can't then follow up. The most important person, and I will re-emphasize this on our team, is our porter. And in a major incident, one porter may be servicing multiple theatres, so not overloading them, not putting too much pressure on them, ensuring we know where they are and they're being sent appropriately to the lab is the most important thing. Next slide, please. E is efficiency and effectiveness. We everybody's talked about forward planning, being situationally aware. And as much as I talked about leadership just now, I want to emphasize the importance of followership. If everybody has the right role and expertise and they're able to do their job, leadership is really easy. It's much more important to role model good followership to make sure that everybody in the room is doing their job, but they can be seen to be doing each other's jobs, and it makes for a much calmer situation. And part of that is the communication, but also anticipation of what is going to happen next when we think the operation is going to be over, if it's in our operating theatres or in our interventional radiology suites. And then making sure that we've handed over to our intensive care unit colleagues, if that's where our patients are going, or to our recovery staff. So everybody is anticipated, ready to receive whatever comes next. Next slide, please. Oh, another slide. So know what there is and where it is. I am always surprised. It surprises me every single day, and every single time we run an audit or a questionnaire in our trust about people's knowledge of the blood fridges and what's in them and how long it takes to defrost things. You will get such a wide spectrum of answers. It sometimes just floors me. Important thing that most people don't recognise, and that includes my senior colleagues who do know how long it takes to defrost certain products, is the transit time it takes to get blood from the lab up to the theatres or to the theatre fridge. And at St Mary's, for example, it takes 11 minutes to get from the Mint Wing, which is where our blood labs are, to the 4th floor operating theatres in our Code Red theatres. And not appreciating that means that we can't be aware of what we want when we want it. So it's really, really, really important that you anticipate what you need, know where your porter is, know what the lab is ready to give you, and then almost set up a timetable. And we do this on a window where we say at 12:10, we're going to send the porter to go get six FFP, 1 pool of platelets, 4 cryoprecipitate, 2 grams of fibrinogen concentrate, or whatever it is that we're requesting. So we make sure it's all written down, and then it's ticked off so that we're aware of what the next steps are. Big part of that's changed our lives in with surgery that it has major bleeding, it's point of care testing. And if you have access to point of care testing, and we're very fortunate to have the TEG 6 at St Mary's, we use it absolutely to help us make decisions about our patient's blood management further on. Next slide, please. Like I said, fibrinogen. My other hat is a vascular anaesthetist. I was saying to Heidi, in fact, yesterday, that I don't think I've used defrosted cryoprecipitate over a couple of years now, because we're very fortunate to have fibrinogen concentrate. Please remember those patients who are potentially on other forms of anticoagulation, and we might be having conversations with you guys as experts about how we manage those anticoagulants that might be in our patient systems, things that we don't deal with normally on a normal day-to-day basis, because elective surgery, most of the patients who are on normal anticoagulants will have had them stopped for their surgery. Next slide, please. I want to emphasize again what Martin just said about the hours and days and the weeks, and also what Kate and Alistair have said in the previously, that it's all about having the right mental capacity and bandwidth. We are all different sorts of people. We're all different psychologically. We're affected by things differently. The Grenfell Towers, I had friends and colleagues who were involved in the Grenfell Flower Tires who had houses and apartments there, and it continued to affect them and our colleagues for many months and years afterwards. So I cannot emphasize enough how important it is during the day of an incident to ensure that people are getting rest periods, that they are getting food and drink, and that you set up a system to ensure that those things will happen. Hot and cold debriefing, I won't kind of go into too much because Martin's spoken an awful lot about it. Cold debriefings often happen for our hospital as a whole, and it's really to get the lessons learned, and that's really important, but also to ensure that you have set up a system that allows for your colleagues to come to you when they don't feel ready or they're having issues, because often stress is something that we aren't able to see easily unless we know people really, really well. As an innovation lead, I'm very enthusiastic about improvement and how we can make things better. And I think the patient voice and those patients who have been involved in major incidents and mass casualties and what they have to tell us will help us collaborate and build a better system each time we have to go through this. So these are my take-home messages. As anaesthetists and as clinicians, we're trying to make decisions early based on a lot of uncertainty, and it's an ever-changing thing. So it's all right to change your mind and change a decision later in the stage of a patient's care. But communication is key. Timing is key, because being efficient and effective means that our patient outcomes are better. Involving the MDT is the only way forward. Please never underestimate the stable patient. The first patient I treated for Westminster Bridge, I was told was a patient that had come in from another incident entirely, and it ended up that he had jumped from Westminster Bridge in order to avoid what was happening, and actually he nearly drowned, and it wasn't recognised till much later on, almost 2 days later. So forward planning for all needs that we have. Thank you.
Sadie, it's a tour de force, and I appreciate that you didn't run your VVOX for purposes of time. I think on one of your slides you had something there about food and drink for staff, and that's something we're going to do in a minute. But in terms of picking up some bits and pieces, you emphasised patient blood management several times there, which is something we're all used to. And certainly Chris will tackle stop the bleeding surgically, but I think you've emphasised stop the bleeding through hemostatics. And adjuncts, and that also included a reference to diagnostics, because although we're talking about transfusion, we're very mindful of the whole of the clinical laboratory service, but actually increasingly we are using diagnostics.